Dr. Jigyansa, you can start with the intro. Then we'll keep it very short. We'll probably wrap up the whole event within 45 minutes. That's the whole agenda. So we want it to be as interesting as a case seminar, but no, as short as a good lecture. So combining both the criteria as we have designed this program. Dr. Jigyansa will give you all the details. Dr. Jigyansa, over to you. You can start.
Yeah. Very good evening to one and all. I'll just share my slide and then.
Ma'am, I think your mic has some issue. Your voice is echoing, ma'am.
There's an echo in the voice.
Now it's good.
Now it's good, ma'am.
Okay. So a very good evening once again. So this particular program is there's an echo still there, no?
Yes, ma'am. Like if you turn down your phone volume or a laptop volume, it will be better, or use your earphones, ma'am.
Okay now? I think hopefully it's fine. So this particular academic discussion is brought to you on behalf of BIIPbSAR, that is Bhubaneswar Institute of Interventional Psychiatry, Behavioral Sciences and Research. So we are a small group of academia, and we plan to start with the first super specialty mental health services in the state of Odisha. So ours is a small team, and the team consists of Dr. Narayan Mahasuar, who has been the founding member, and he has been associated with us since the beginning of it, and is currently based at Australia, Melbourne, and he heads the addiction unit at the BIIPbSAR Clinic Private Hospital. So we are blessed to have you, sir. The second team member with us is Dr. Ravan. He has completed his MD from CMC Bangalore, and he is currently a very senior psychiatrist, and he works with us and this team and guides us. The third person in the team is Dr. Udit Panda. He has done his addiction psychiatry from NIMHANS, and he's the speaker for the day as well. And I'm Dr. Jigyansa, and I've done my fellowship in child psychiatry, and I'm also a member of this particular team. So what we bring here today is we thought we'll get together into an academic forum, and we thought of bringing to the forum interesting cases, particularly of clinical interest to psychiatry, and we thought of discussing the evidence-based guidelines available for that, and what the literature says about the current management practices that we have and the challenges that we face in particular situations. So we thought we'll make it fortnightly case discussions. Anyone and everyone is invited to bring about cases. Maybe you can share the cases that you want to present with us a week in advance, and we'll definitely allow all of you who are here, and maybe you can share with your friends also, all young psychiatrists, all experienced clinicians, because we want to learn from the collaborative effort of each one of us. And to be a very brief program, 45 minutes to 1 hour, and we want to keep it as engaging, as interactive as possible. So with this, we bring to you the first fortnightly case discussion starting today, and I invite Dr. Kumar Panda to begin with his presentation for the first session. We have Dr. Deepak, who will be the discussant for today's function, and we have Dr. Ravan, who will also be the discussant. I'll be the moderator. So over to you, Dr. Panda.
Before I begin, I would maybe request Dr. Jaiprakash to speak a few words about this Monday Roundtable concept. It is his brainchild, so maybe he can throw some light on what exactly we're going to be doing in every fortnightly when we meet up for 45 minutes.
This is the first edition of our program. Let's see how we can make it more interesting and academically more thrilling. And most of these cases will be bit different from the day-to-day typical or textbook discussion we have in our departments, mostly of schizophrenia, OCD, bipolar, and all. We have to see what are the interventional variety or interpersonal diversity in our each department cases are we are seeing, but this platform will provide each one of us to bring our case and discuss it here, so that across department in this country people will come to know about it. So with this we have now this time allotted is 5 minutes and we almost completed that. And I invite the first edition speaker, Dr. Udit, and he has done a hard work, and his intellectual brain. Let's see what he speaks and what he brings to the table for discussion. It's over to Dr. Udit.
Thank you, sir. Very kind words. What I'm going to do today is I'm going to summarize a case maybe in the next 10 minutes. Then I'll put up a bunch of questions to the forum. I'll probably sit down and listen to the answers as all of you get engaged and give it. So I have made a PPT to aid my presentation. I'll share that in a minute. Is it visible? Give me a thumbs up if it is visible.
Yes, sir. It is visible.
Great. Am I audible clearly?
Yes, you're audible and visible, sir.
Excellent. So I'll begin. So let's call this case as the case of Mr. S. Just give me a moment. I'm unable to put it in slide share mode.
Actually, you need to share it again. Yeah, it's in the slideshow mode, sir.
Yes. So this case is that of a 20-year-old male who came to our facility about a year back. He is a first-year engineering diploma student now. Lives in a joint family in an urban area and belongs to middle socioeconomic status. Whatever information I have on present today, we have received it from the old medical records of this patient. I've spoken to the patient himself and the father, and the information has been adequate and reliable. I'm not presenting in the detailed case record pro forma as you normally do in a case seminar, but rather giving broader summary of the case. The total duration of this case has been 5 years. It was very insidious in onset and progressive in course. No obvious precipitating or perpetuating factors for the illness I could identify. Coming to the symptoms, I have divided it into symptom clusters so that we'll be able to distinguish between one symptom from the other. So the first symptom cluster started when he was about 15 years old, so like 6-7 years back. Excessive thoughts of contamination started having. It was mostly restricted to bodily fluids, any sticky substances that is in the immediate environment, or other environmental contaminants like phenyl in the washroom or sad soap, things like that. With that started out excessive washing behavior. Initially it was very mild and unnoticeable by others, but with time it became increasingly time consuming, and he started spending 3 to 4 hours per day in this washing behavior. With this excessive washing and the repeated intrusive thoughts of contamination, he also started experiencing intrusive images of him urinating on his village goddess. Images were in his mind, and he was unable to stop it even if he wanted. He belongs to a very religious family and kept repeatedly asking his family members if he has done anything that is immoral, and started chanting hymns of the goddess in a very futile effort to get rid of the images, but the images kept coming. Maybe a year went by, then he started showing repeated checking behavior, because he said that I was unable to satisfy myself. Repeated checking behavior in the sense, example should be he started checking up the water taps to see if it is closed properly, and you do it for like minutes together, maybe up to an hour or so. Repeated checking of the written submissions to the class. He was probably in class 11th or 12th that time. So much so that he was unable to finish the class assignments. Started checking electrical switches to see if it is switched off, and he used to do it like for 15 minutes, 20 minutes. So that is the third symptom cluster that came up. The fourth symptom cluster came up about 2 years ago. He started doing things in the repeat sequence of 3. He has to look to people 3 times when people are passing by. If he has touched the object, he has to touch it 3 times. If he's writing a word, he has to write that word 3 times or 3 words in a sequence, then he has to take a pause. If he's scratched his body, he has to do it thrice. So something like Sheldon Cooper. So started repeating it over and over again, and he was unable to stop. The 5th symptom cluster, which was the presenting symptom that he came up with, has started probably 1.5 years back. Since 1 year, he started feeling as if his legs are touching everywhere he goes, even if it is not. He knew it is not normal, and he was unable to stop it. And so whenever he was passing, he started saluting any objects or person when he was passing, as the religious connotation asked us to do. Just didn't feel right if he didn't do it. For the last 6 months, he started feeling that his penis rather than his leg is touching objects or places wherever he moves. It becomes very bothersome when he's with his family, mother, sister, or father. So that constant feeling that his male part is touching other people, that has made him withdraw socially, and he is now bound to his own room. He describes this to be the most distressing symptom of his life. What happened to the symptom clusters over time? The intensity of the repeated thoughts of contamination and the washing behavior has waxed and waned in the last 5 years. Now it is very minimal, as the reports. The intrusive thoughts of him urinating on the goddess has almost disappeared after he started feeling that his legs are touching everywhere. So that symptom came. The images of him urinating on gods and goddesses has disappeared. Repeated checking objects and the associated doubts that he have, it has reduced in intensity since the last 1 year, as he reports. The preoccupation with counting by numbers of 3 or the repeats of 3, it continues. The feeling of his penis touching objects continues in a higher severity. And most of his day is occupied with these symptoms, making him dysfunctional in all domains of his life, be it his academic pursuit, his family life, his social life, every domain. So there has been no negative history. I'm not going to go into the details. I just mentioned there's no free-floating anxiety, no delusional beliefs, no thought insertion, no fast-track symptoms, no tics, no history of ADHD, no head trauma. So treatment history. He has been under treatment maybe 6 months after the symptom onset. There has been trial of 3 SSRIs, as I could infer from the treatment records. The dose and the duration has been adequate. He has been diligently treated by a few psychiatrists locally. So first trial was of fluoxetine, was taken to a dose of 120 milligram and was given for 6 months, but apparently did not have much benefit. Then he was given fluvoxamine. Fluvoxamine, he had partial response in the sense the washing behavior came down. It was continued for a year, but then again when the repeated checking behavior came in, fluvoxamine was withdrawn and escitalopram was started. Escitalopram, he was unable to tolerate it well. Thus it was discontinued, and when was started, venlafaxine up to 300 milligram. That also he did not tolerate it well. So he has been on a combination of different SSRIs for a considerable period of time. There has been no significant response to fluoxetine or escitalopram, a partial reduction to fluvoxamine. Along with the SSRIs, he has also, with the treatment has been augmented with lithium in past up to 600 milligram, anacetyl-cysteine up to 2400 milligram, risperidone up to 3 milligram, and clomipramine up to 75 milligram. He has also received ERP for 2 months from a local therapist, but he has been largely non-compliant. 2021 onwards, we have started treating him. So what I have done is we initially switched to clomipramine and started building up the dose. He tolerated really well, and up to 200 milligram we gave. Then we added sertraline, that 200 milligram he is receiving. Considering the risk of seizures, we have added valproate, and that's 500 milligram, pardon for the typo. He is also receiving risperidone 2 milligram and clonazepam SOS now. And there has been partial reduction in the symptoms of checking, but this feeling of his legs or his private part touching to other people, that continued, and he has not been complaining of any prominent side effect. Premorbid traits, I am skipping this. Mostly cluster C personality traits I could identify. More internalizing temperamental trait was present. Examination finding, there has been obsessive sexual thoughts, pathological doubts, normally has an anxious effect, and there are mental compulsions and the compulsive behavior touching objects in the sequence of 3. the compulsive behavior of saluting repeatedly, it has come down. The baseline Y-box was 29 when I started seeing. He was already on these medicines. With that, we made a diagnosis of OCD, obsessive compulsive disorder, with mixed obsessional thoughts and acts. A decision to start ketamine came from the fact that he has been a poor responder to a lot of first line medications. His high symptom load is making him absolutely dysfunctional, homebound, and kind of a therapeutic nihilism that came into us. So we thought we'll try it out. We went through the literature. So we did it as an outpatient procedure in our daycare. We used the racemic ketamine hydrochloride. It comes as a 5 ml vial. You have 1 ml containing 50 milligram of racemic ketamine hydrochloride. So combination of R and S and so on. There has been multiple routes with which ketamine has been administered. You can use it IV, you can use it IM, you can use it subcutaneous as a spray, you can use the ketamine syrup. We chose a subcutaneous route. We gave a sub-anesthetic dose, 0.5 milligram per kg body weight, subcutaneous. We have used an hypodermic insulin syringe of 40 international unit, titrated the dose with 0.5 milligram per kg, and we gave it. Probably 30 units he was receiving, as far as I remember. The initial administration was 5 sessions over a span of 2 weeks. So the first week he received 3 sessions, the next week he received 2 sessions. Ketamine was administered as a daycare procedure. When he was receiving it, we continued to measure his vital functions, BP, pulse, respiratory rate with oxygen saturation, and prior medications as he was taking was continued. What is the experience? Patient's consciousness remained intact all through. There has been, he reported a little bit of motor dissociation, in the sense he said, I'm unable to feel my hand or raise my hand. That happened for like 1 hour after the procedure. Dizziness and nausea was reported, but complete recovery was there within 3 hours of giving the injection. We did not find any psychotic experience. We do not find any manic symptoms. We do not find any conceptual disorganization as normally side effects of ketamine as we know it. He gave us the idea that he's having entactogenic experiences, in the sense he said he's able to see his life clearly and he's able to understand what God is, and he feels that he is in unity with his surrounding and everything. Physically, there is a bit of tachycardia, maybe pulse rate rose by 10 beats per minute, and systolic elevation, BP elevation was by 10 millimeter of mercury. So that was something that we just observed and managed. Outcome: the significant improvement in symptoms after the second dose. After the second dose, he said that my feeling has almost stopped. The feeling of his penis touching other people and object. He said that I am continuing to experience the compulsion of doing things in the repetition of 3, but the feeling that was bothering him the most, it has almost vanished. So subjective distress was reduced. He had taken admission 6 months prior, but had not gone to his college. He started going to his college. The functional recovery was in. But after the whole session of 5 sessions in 2 weeks, we stopped giving the injection for 1 week. The day he came back for follow-up, he said, for the last 2 days, I have all the symptoms coming back to me again. So re-emergence was there. We concluded a very poor carryover effect of ketamine, a therapeutic effect of ketamine. This is the Y-box score, kind of confirming whatever I've discussed. Pre-treatment, it was 29. 1 week post-treatment, it was 27. But in between, it was undulating between 14 to 17. So we had a fix on what to do. So we thought we'll probably continue giving ketamine for another 4 weeks or so. We gave that. The symptom remission started again. He was stable. But upon attempting to increase the space for more than 1 week, we tried it for 10 days and his distress increased. So right now he is on ketamine maintenance once weekly subcutaneous at a dose of 0.5 milligram per kg body weight. So with that, I have 10 questions for everybody, including our esteemed discussants. Can we use ketamine in severe cases as a first line drug for rapid resolution of symptoms till the approved agents like SSRI start acting, because there is a delay in action? What is the role of ketamine in treatment resistant OCD, like what we're dealing with this case? Will every case be a magical responder like Mr. S? So if not, then who are the patient group more responsive to ketamine? What is the optimal dose of ketamine to treat OCD? Whether it is 0.5 milligram per kg, or can we maybe tweak it a little bit more, 0.6, 0.7, 1 milligram per kg? Can we keep people in long-term ketamine maintenance? What about tolerance to ketamine? Does it develop? What about the addiction to ketamine? People have been reported to use ketamine as a drug which can be abused. What is the addictive potential of that? What are the long-term side effects and how do we go about that? So there's something known as ketamine bladder syndrome. So it is toxic to your urinary tract. So how do we detect that? How do we go about that? Should it be a daycare procedure at all, or we did a mistake in doing that? And if not ketamine, then what are the alternatives that you have to manage this case now? So with that, I stop my presentation. Over to you, Jigyansa. You can start the discussion.
Thank you, Dr. Udit. I think this case provides us quite interesting areas for discussion. I think you have raised more questions than actually answering the queries. So maybe we can request Dr. Ravan, Jaiprakash Dr. Ravan, because he has also been seeing this case, like in between once or twice in follow-up. So what is your opinion about the case, and in particular the role of ketamine in OCD? What is your experience, and how would you say this particular case brings into light what kind of scientific angle? Dr. Ravan.
Sir, you are muted. Please unmute yourself.
Yeah. So thank you, Dr. Udit. What I understood about the course of this illness and the other patients which we have given ketamine, that mostly those who are non-washer, those who are having contamination and washing, these are the people who don't respond dramatically in our case series with ketamine. So we can now in clinically we are in a state to tell, and you can see in your own patients also, the non-washer people, those who are having blasphemy, sexual obsessions, and doubts and checking, varieties of OCDs, these subgroups where the ketamine is working better. Maybe in the neurocircuitry, the physiological and the etiological underpinning is bit different in washers when compared to the non-washers, those who are having more of blasphemy, sexual obsession, and others. So when we go to the original finding of this, whether the improvement is persisting or not, whenever we have given spaced these patients, we have found out that some of the symptoms are started creating some problem for the patient. Not that he had gone to the initial very distressing OC symptoms, that his legs or his limbs have been touching the other people's private parts and other things. These things were not that much, but it was, yes, there was some amount of relapse in the symptoms. So what I mean to say that ketamine in a very distressing OCT can be taken off as a OPD procedure in a subcutaneous mode, and there is some relief for some patients, not for all, but some patients. So we need to identify this clinical subsection of people among OCD who are good responder to ketamine. Thank
One
you.
interesting question is there in the chat box from Dr. Markande, I believe. Sir, if you want, you can actually unmute and ask the question. It's a very, very interesting question to be discussed.
Sir, it is like you have mentioned that feeling that the private part is actually touching.
Yeah. Dr. Ravan, sir, Dr. Markand is asking if it is a tactile hallucination or the private part is actually touching.
No, it's not tactile hallucination. It is a thought that he might being close to the mothers and the sister who are there at the home. Their private parts, his legs is in that direction, or he's sitting in that direction, or it might touch. Those kind of obsessive doubts or sometime images would disturb him. In the tactile hallucination, the thing is the perceptual distortion, where the patient will get the sensation. I think there was no such feeling, but it is definitely a phenomenological good differentials. Thank you for that point. Thank you.
Yeah. Dr. Markand, one more clarification. His insight is actually pretty present. He understands the ego alienness of the thoughts. He understands the intrusiveness of the. He expresses his helplessness in a very vivid way. Doctor, I'm unable to do anything about the thoughts. Please try to stop it. That's why probably his his returning back to functionality was so rapid, because he suddenly probably 2 to 3 days he found his relief pill. That's why I went back, joined his college, started going to classes. Unfortunately.
So likely the individual had comorbid depression, which we usually see in our patients, and likely the possibility, if we see the profile, longitudinal profile which has been going, we have given ketamine, he has responded beautifully within 2-3 days, and subsequently after the completion of the dose of ketamine, he has fallen back to the same BIIPbSAR score. So can it be a possibility it's a comorbid depression in which depression has slightly improved, in which he thought that things are improving and now he has fallen back to the same track?
We thought Markande. Yeah, thank you for that beautiful question. Maybe request Dr. Deepak to kindly answer. Maybe we have an expert with us. So it will be really great, sir, if you can opine on this particular point.
Yeah, I agree that many of the patients do have comorbid depression, and we know that ketamine is probably one of the fastest acting drugs available to us as an antidepressant. And that is one of the things we know, that depression, not just as a comorbidity, but that people experience their OC symptoms, obsessive compulsive symptoms, in much more higher intensity when they are depressed. So it's a bidirectional relationship, and it's quite possible that that this person might have responded because of that. I would just take it forward to tell that it's also has been tried a lot in NIMHANS, and in OCD clinic. We have published a case series of multiple cases which have been given the intravenous ketamine and the response to it. Unfortunately, for all the patients, the response is not as good as the patient seen by the BIIPbSAR team, and I believe that this patient has responded wonderfully well. So there is obviously a possibility that needs to be considered, whether a comorbid depression was there. However, then we have also seen that this particular patient has been given a very good doses of good and SSRIs for a duration that we consider as adequate. So yeah, this is something that is very interesting, that has been considered by the treating team.
In the interest of honesty, we have our failure stories with ketamine as well. This is maybe a publication bias, if we can call it.
Yeah. So yeah. Yes.
Sir, if you permit.
Yes, go ahead, sir.
So like if we see the onset of the illness was at 15 years of age, so likely that goes towards a more of poor prognostic factors. And over a period of time, since the disease has evolved, if we see magical thinking was also present. He was stretching everything for 3 times. So likely pre-morbidly temperament may be of an ancastic type.
An ancastic, Sir, it's more whatever the father's information was there. It's more in the line of a combination of schizoid versus anxious avoidant traits. So it's difficult to delineate. He mostly remained aloof. He has very poor social interaction. Very limited number of friends. Kept mostly to himself. Is not very vocal about his needs and all. So that thing has been there. And in Kastik, I could not really find any obsession or maybe any preoccupation about rules and all. So that's why I did not comment on that.
Sir, you also mentioned that there was some kind of stereotypy or mannerism, like you were saluting to that as per the rituals which you have seen.
Salute would be a misleading word. So that is something that we do. Whenever we touch or our feet touches anything, we consider God is present everywhere. So basically, we touch that and we keep it on our forehead. So that is something that he did.
Is it a kind of stereotypy which is
I have classified it as a compulsive behavior in response to an obsession of my leg touching everywhere.
But touching these feet of everyone is not responding to his anxiety level, if I'm not wrong, sir. And if we see, it is like the development of any psychotic illness which has manifested in a different form, which we are treating only the tip of the iceberg and not finding the underlying, maybe because the patient has not developed such kind of personality or the disease has not came out completely.
Barring this, we did not really find any other core psychotic symptoms to be able to consider psychosis. He has preserved insight. He gives a very clear description of how obsessive ideas come and how he responds to them by either doing some mental compulsion or doing some physical compulsive actions. So only basing on stereotypy, it's unlikely. But yeah, you were right. People with early onset OCD, they sometimes go on to develop schizophrenic illness. So that is something that has been seen. So maybe future will tell. As of now, OCD is still our first diagnosis for the case.
Right, sir. Thank you, sir.
Thank you, Dr. Markande. This brings us to another interesting review of literature that I was going through, and I came across a few RCTs where they have tried to specify, which particular type of OCD responds to ketamine and what kind of OCD does not. So maybe this particular case has more of obsessions. That is what responded to ketamine is point one. And I'm not very sure about the second finding. There was some case series which mentioned that if there is comorbid depression, that is not a good indicator for response to ketamine. But I'm just curious what could be the underlying neurobiology, or maybe our experts could explain, because this question was also brought about by Dr. Markande, who said that possibly it is the depression that is responding to ketamine and not OCD. So the takes on our discussants on this particular question.
With the permission of the moderator, can I ask to other people, like if anybody have any experience with ketamine? Dr. Sumit, Dr. Professor Sukla, and everybody has joined in, and if they can share their clinical experience, so that will be useful for all of us. So anybody can unmute and talk about their own experience and their first-hand understanding about using ketamine in OCD. Any?
Sir, you have to direct your question.
Okay, so
Dr.
Sukla sir can guide us. Any experience, sir?
Yeah. Good evening, everyone.
Good evening, Dr. Sumit.
Yeah. Actually, I experienced using ketamine in depression, but in OCD right now. So this particular case discussion is giving a new insight for the indication of ketamine in OCD.
I have a question sent to me by private chat. Dr. Ratnesh has asked what was the original consideration behind OCD. Dr. Ratnesh, this is a theory that I have in my mind. So there are ketamine is a NMDA receptor antagonist. So there are two NMDA receptor antagonists that have been proven to be at least supplement the action of SSRIs in treating OCD. One is memantine, one is riluzole, I believe. So maybe that's how the idea of using ketamine must have come. Ketamine is a stronger NMDA receptor antagonist, so that might explain the rapid onset of action, anti-obsessive action in this case. So memantine normally takes for about a month or so to be able to show its effect. So that is probably how the idea of using ketamine might have come. But how the idea of using memantine has come, that I have no idea.
Thank you, sir. Thank you so much.
I would like to ask a question to Deepak. Deepak, I have a fear that I have made this person dependent on ketamine because he keeps coming every week without missing his appointment. So, is there a possibility that dependence to ketamine has developed, therapeutic or maybe iatrogenic dependence?
Yeah, to call it dependence, now we'll have to go back to our addiction psychiatry and look at what are the expectancies. Now, for this poor chap, the expectancy has been relief from his obsessive symptoms, and it's more of a negative reinforcement rather than a positive reinforcement from ketamine. But I do believe that, yes, even with ketamine, the trips, good dissociative experiences, as you mentioned, a flashback of memories from the life has been postulated. I'll just briefly tell our experience with ketamine, not for OCD, but because I work in addiction psychiatry, and people do talk about a very different kind of out-of-world kind of experience with ketamine if they have those kind of experiences. But yes, now what is the frequency of ketamine that needs to be given? How frequently, how long can we continue this? Do we have an alternative to something that has been useful or found to be useful and such dramatic improvement in symptoms? Yeah, so these questions we need to find answers to, especially with the kind of side effects that you have spoken about in the question, that long term we know that it causes sympathetic stimulation, and for brief period the person's heart rate as well as pulse rate improves. In certain situations it may not be, like this particular case it's just 10 millimeters of mercury, but in certain situations it may be even 30 to 40 millimeters of mercury of systolic blood pressure rise has been documented. So yeah, long-term side effects as well as addiction potential is something that we need to take consider. But then yeah, these questions do not have an answer really. The depression studies, even though initially people were talking about monthly or maybe fortnightly injections of ketamine, but nowadays more and more papers are coming that the effect may last as less as maybe a week for patients, even for depression. So as ketamine is being studied and for various indications, and as more and more research will happen, maybe we'll have answers to this. But as of now, it's working as a therapeutic agent, I would say. What was your
my thought behind considering dependence, because rather than talking about his symptoms for the last 3 sessions or so, he prefers to talk about the experience of ketamine intoxication, in the sense that how he feels. He is able to be in touch with his inner God, and he is able to move on a derealization plane, and how he is able to see his life through and through. He's able to analyze it clearly when he's in that period of intoxication for 2 hours. So that is why I thought of this.
Yeah, you can obviously see some red flags there, or I would say amber flags, at least as of now, that it's the positive experiences now that is coming back to us. And yeah, so something that to ponder about in your next few sessions, I would say.
Right.
Thank you, Dr. Deepak. Dr. Jigyansa, can we ask Dr. Prasanth Mahapatra, one of our senior colleague, and
Dr. Shukla is there.
Yeah, Dr. Shukla sir also. Can they give their experience if they have with ketamine, and what is their take on this issue? And then we go to the residents. If they have anything to share, we can. Prashant bhai, there, Prashant sir.
Not audible. Prashant Mahapatra sir, you're not audible.
Sir, you can remove your microphone. You can remove the earphone and it will come. The audio will come.
Am I audible now?
Yes, sir.
So actually, I don't have any experience with the ketamine for OC symptoms. But thing is that if this OC symptoms is associated with psychotic symptoms, that means OCD is associated with schizophrenia. And if you give ketamine also, so what would be the drug of choice for schizophrenia?
So ketamine was likely to cause psychosis, so it will probably worsen the whole situation. But it's not a preferred agent at that point of time.
So you'll have to avoid ketamine.
That would be probably one situation where ketamine would not be considered. Rather, other strategies, maybe anastyl cysteine augmentation or lamotrigine augmentation, or even augmentation with BIIPbSAR, things can be considered.
Okay. How many cases you have treated with ketamine?
Sorry, sir, I didn't get a question.
How many patients you have treated with ketamine?
Till now, my experience would be between 12 to 15. I have to go back and check the numbers. So maybe below 15, but a good number of cases I have given for OCD.
What is the response then?
I believe this kind of magic has happened twice. One in our inpatient unit, one in OPD EA. Rest, some people are partial responders in the sense that the YBOX score actually came down between 25 to 35%. And most other cases, they had absolutely no response. So 3 patients actually dropped out after 2 sessions. One person had an exacerbation of anxiety. So we had to basically stop the ketamine therapy in the first session itself. So,
are the patients comfortable with subcutaneous ketamine instead of taking anti-obsessive drugs?
So we are offering it to people with the pre-counseling that it is something that has come anew and may cause a rapid reduction in symptoms. So if those people who are giving consent, only them who are giving, we are normally giving it in a supervised daycare place where our residents are through and through observing their vitals and all. So there are people who are coming back. Mostly all of our cases are treatment resistant cases only, people who have failed multiple trials of medications.
Okay.
This brings us to another important question in the chat. Because we are talking about treatment resistant OCD, or maybe this particular case was difficult to treat OCD. People have asked questions about why not consider ECT instead, and maybe you are considering ketamine. That is one point. And second, maybe the question is, do we actually wait till treatment resistance to develop before we give ketamine? So these are two questions. So your comments, please. Dr. Deepak, Dr. Ravan, Dr. Prashant Mahapatra, sir.
See, this ECT for OC symptoms, I think there is no evidence, scientific evidence to back this type of intervention. So it will be difficult to substantiate if something happens during ECT for OC symptoms, then we'll be in the legal problem. The other question was, can you just repeat the second part of the question?
Should we wait for treatment resistance?
Yes, these people who yes, I got it. So we have adequate, as Dr. Deepak was mentioning, the adequate dose, then the adequate duration was waited, then some amount of CBT was also tried, and then the subsequent addition of the other SSRI or clomipramine was given. With that also there was very less improvement, and then these people are been giving ketamine. As Dr. Udit was mentioning, in our combined effort, where the almost a dozen of patients or 12 or little more than that, but the patients who are coming back for these are actually good responder, and they are mostly male, and they have this non-washer OCD, and they have really no major symptoms of side effect, as Prashant sir has raised the concern that side effects and tolerability. But the problem who are having depressive, the 3 women who are having comorbid depressive symptoms, they did not do well, and we have to discontinue after 3 to 4 doses of ketamine over a period of 2 weeks. And after that, we said, no, you are not getting any benefit, so we will not continue this therapy. So, as it is also observed in certain meta-analysis or systematic review that people having comorbid depression, maybe the circuit is different, the nature of medications, nature of neurotransmitters.
So you got muted. You got muted, sir.
Given or their response, getting a response with ketamine. So I don't know whether we have less time now. Can we go to residents if they have any questions?
We'll take two more questions, then we'll probably wrap up.
Okay. So is there residents like Titas, Dr. Titas, Dr. Shreya, and Sumaila?
Dr. Karan has asked a question in the chat.
You can ask Dr. Deepak and Dr. Udit are there, so they can help you to get some of the answer. And my thing is, can we rewrite the guidelines of OCD treatment after ketamine?
Sir got frozen probably. It's online.
Can it be clearly in the therapy to reduce the distress? So that is one of the things I wanted to make a point. And about the introduction of RTMS and ketamine in this group of difficult OCD as well as in the early part of their treatment. Okay, so any other comments or any other questions is encouraged from the residents. Karanbir Singh has asked something in the chat box.
So, Karan, there are two kinds of ketamine that is normally there, no? R and S enantiomers of ketamine. So, R ketamine versus S ketamine is now approved by FDA for use in depression. What we have for anesthesia induction is a racemic mixture of both of them. So, it's ketamine hydrochloride. That is something that we have used. I don't think India has a supply of S ketamine currently. So if and when that comes, and if someone like you conducts a good double-blind randomized control, so maybe we'll get the answer. As of now, there is no scientific answer on which is better. So sorry for that.
We also have a question from Dr. Ditash. She says, sir, as per my understanding, can we conclude that if the patient is having comorbid, moderate or severe depression, we should think twice before considering ketamine, as it may be the depression that is getting treated instead of OCD. Okay. And she's also skeptical to use it in a patient who has obsession of contamination. So comment of Dr. Deepak, if she takes home that kind of a message, what would be your response to that, sir?
Yeah. Then there is, let me be very frank here. There is currently no guidelines talk about it as an agent that you should consider if depression is present or if depression is absent. It is something that you consider maybe after you have failed everything under the sun, and the next option is either a deep brain stimulation or psychosurgery. And this is even as Dr. Professor Ravan was saying that it has featured in the latest IPS guidelines for OCD, and there also it has been mentioned that it just appears as an adjunct treatment when everything has been expended. And in this particular case, especially that he has already failed a trial of 3 SSRIs in very good doses, what we call as ultra high doses. Trial of venlafaxine has been given, trial of lithium, augmenting agents of antipsychotics has been done. Everything has been done that we can actually do for this patient. And of course, clomipramine has appeared there. So this is something that then we venture into a territory that is all experimental treatments, and it has been called an experimental treatment everywhere. That ketamine is, as of now, experimental treatment. Some people respond to it beautifully. Majority, unfortunately, may not respond to it, and thus it's very difficult to point out which patients respond, which do not, also because the response rate itself may not be so high. As Dr. Udit has mentioned, that 2 cases out of all the cases have responded wonderfully. At NIMHANS, 1 case responded wonderfully, immediate remission. 0 is the score of white box out of 14. 2 cases partial response, 11 cases non-responsive. So it's very difficult to say what is helping, what is not helping. As Dr. Prashanta was asking, one of the actions, even if we keep talking about NMDA receptor antagonist action, the final common pathway is that NMDA receptors on GABA, then GABA comes down, and then increase in the dopamine is the final common denominator that we are seeing. And then thus we may see these dissociative episodes and these quasi-psychotic kind of episodes may happen. It was actually, ketamine came up as a safer alternative to phencyclidine when it was brought in. So yeah, in cases of psychotic patients, in cases where there is comorbid schizophrenia, we generally tend to refrain from giving ketamine. But what is in the patient that we should look at to say that it will respond or not? Current knowledge is based on case series at the max. No, nothing more than that. Yeah.
So to conclude, we need more robust evidence to actually conclude something like that. So another question which has been there consistently is, what about the different routes of administration, like the subcute route versus maybe IV or IM? Any comments on that particular question?
I'll probably try to answer that. So it's all gray right now. The rate of absorption would be different, but the anti-obsessive effect of ketamine is not something that you see immediately. It normally takes about maybe up to 200 hours is something that is written. 4 to 200 hours was the range. So there is one theory that being a anti-glutamate or anti-NMD receptor antagonist, it somehow causes a presynaptic blockade, and there is a prefrontal release of glutamate. So that is excessive. As you know, glutamate has a lot of, it has influence on almost all the neurotransmitters, and kind of there is a cascading. So maybe that is something that happens, and ultimately we see the anti-obsessive effect in people who were seeing. So it's unlikely that the route is going to determine the long-term response. Maybe depending upon the setup that you have, because if you're giving IV, the symptoms are going to be immediate. And if you're given for the first time, you do not really know someone who's going to have a hypertensive crisis, or someone who's going to develop malignant tachycardia. So that was our primary reason for choosing subcutaneous. The absorption is going to be a little bit slower, and will probably have some time to handle if things go haywire. So that is why a scared little hat went for subcutaneous. But I don't think route is the determinant on the anti-obsessive effect of ketamine. That's my lesson from whatever I have read.
Thank you, Dr. Udit. This question by Dr. Deepti: does the dissociation experience during infusion predict the response of ketamine?
That is something our resident Dr. Anand is doing a RCT on depression. He has been consistently reporting that people who are having a dissociative episode during the ketamine infusion, he's giving it IV. It's a placebo-controlled trial, but somehow he's able to figure out who's taking ketamine. People who are dissociating, they are having a prolonged carryover antidepressant effect of ketamine. So for depression, it might be valid. In my experience, I have not seen that happen.
But there is a review in the review of literature. There is one case series which also demonstrates a finding in a similar trend, where they also report that maybe dissociating during the ketamine infusion is actually a predictive indicator. Okay, maybe we can take one more question, or do we have more time?
Before people I have something to say. So I hope we are able to give you a demonstration on what was supposed to be done in the forum. So this is what we want the residents from all over the country to do, to bring good, interesting, challenging cases to the forum, so that everybody gets the flavor of whatever you have seen, whatever case you have seen, or whatever management you have done. Maybe we'll have a good, healthy discussion, and the knowledge kind of gets spread. So till we start getting cases, one of our team will be presenting, and the discussion will continue every first and third Monday of the month from 7 to 7:45. We are the time. If Dr. Ravan allows, we can actually conclude and let children go.
Before you conclude, there are two questions that why you gave lithium and why you gave fluvoxamine and something related to that. I would like to tell that patient was very suicidal in between. So suicidal that I had to start lithium for him, and then as we know that it has anti-suicidal effect, so agitation, suicidal ideas, and all things improve. And it was not part of the obsessive thought, rather than it was probably a nihilism to treatment, and he was not improving, and he was getting distressed by seeing the improvements and the academic progress of his friends, and he's not able to attend classes. So he was having a lot of suicidal ideas. So therefore that. But somebody has questioned that if there is a partial response to ketamine, what next? Honestly, I would say that the next very good thing is to, when the patient is little better, to sit with him for ERP or any other psychotherapeutic module. And I think that Dr. Saili Misra has demonstrated in two of our very difficult patients that long-term therapy for a period of two months, maybe 12 to 14 episodes, sessions of psychotherapy help them to have a lot of improvement. So psychotherapy is one thing, and keeping the medication in optimum dose is also can help if person is a partial responder or non-responder to ketamine. And thanks a lot to Dr. Prashant, Dr. Sukla, and all my residents and all our residents from different parts of India, as well as a lot of regards and thanks to Dr. Deepak. And it is over to moderator to wind up the session.
That was really quite exciting, and seeing a lot of intellectual discussions happening around a very exciting topic of ketamine in OCD. And maybe the evidence today is still not enough to draw a conclusion. And I hope we raised more questions and tried to answer some of them. So looking forward to an exciting discussion, maybe after 15 days, maybe after 2 weeks. We would invite Dr. Deepak also to join us if we can, and our esteemed senior professors. Dr. Deepak has been extremely instrumental. He agreed in a very, at a small request, he agreed to join the session. We are extremely grateful to you, sir. At the same time, we are extremely grateful to all our residents in particular who did show their enthusiasm in participating and raising questions. So thank you all. With this, we leave for today. Thank you once again.
Thank you.
Hi everyone. Thank you so much. Thank you, Deepak.
Thank you.
Thank you, sir. Bye-bye.
So, sir, with your permission, shall we conclude?
Yes, we can conclude.
Thank you, sir.
Okay,
So,
thank
from
you.
here
Thank
now,
you. Yeah,
thank you, sir.
Lupin. Yeah, thank you.
Thank you, sir. So, from here now, I'm ending this
Oh,
meeting.
sorry.